Hello guys, welcome to the part 3 of the health insurance of the United States. So let's start. The HI continues to have the profound impact on public health policies. In fact, according to the Congressional Budget Office in 2006, its findings continue to be relevant, especially with records of demand elastics. And the study also described a simulation model to estimate how different levels of copayments impact demand, requiring the translation of copayments rates to co-insurance rates. This is relevant because in 1970s and the 1980s, the most prominent method of cost sharing was co-insurance, while today the most commonly used cost sharing mode is the copayment. A copayment is also referred to as a cost sharing, and co-insurance charges a patient directly at the time that a service is rendered, sometimes as a way to control rising healthcare costs. The result of RAND HIE introduced the idea that the cost sharing paired with the managed care helps contain costs without lowering the quality of care or health outcomes. One of the takeaways of the study that could potentially be implemented at the public policy level is that the cost sharing should be low or non-existent for poor individuals suffering from chronic diseases. The HIE research design has many strengths. The study's rejection is of its null hypothesis that the health spending is not responsive to out-of-pocket price is robust. Additionally, the study has a multi-armed design, meaning that the experiment randomly assigned members of the samples from a common pool of candidates to all treatment groups as well as the control group. The multi-arm design allows for the efficient method of testing more than one policy approach to the social problem, at the same time to measure the effects of each approach separately and compare them. Also, a multi-arm design can be used to estimate the effects of separate or combined components of a discrete program. However, the RAND HIE study also has a weakness with its research design. The study may suffer from substantial bias in the original estimate on the account of systematically differential participation and reporting across the experiment. Another weakness is that the spreading the sample over the multiple treatment groups results in the loss of power associated with the experiment. The economist Newhouse, who designed the experiment, wrote a retrospective article about the RAND HIE and mentioned several changes should have implemented if he could redo the experiment. A few of these changes would be: number one is oversampling of the sick poor group of individuals, number two, studying value based insurance design due to the changes that healthcare has gone through over the past decades, and the last one is including Medicare beneficiaries in the study. Additionally, the new house would have liked to add a second or the third HMO to the HMO arm of the experiment. However, due to budgeting restraints, they suggest by Newhouse himself indicate that despite much of the literature citing the study when drawing conclusion of insurance in the healthcare utilization, RAND HIE was conducted in 1970s and its results may be outdated. If trying to estimate whether or not RAND HIE results are outdated, the elasticity of the medical spending should be considered estimated by the RAND regarding its out-of-pocket price, which is minus 0.2. Then it would be important to look at observational studies and their estimate for the income elasticity of the demand of the healthcare services, which typically range from 0.0 to 0.2. However, there are some studies that estimate income elasticity using the different data time series or aggregated state or countries are finding the range of income elasticity of the 0.2 to 1.5. For the purpose of the sample calculation, let's assume the income elasticity to be 0.2. However, the different values within these ranges could also be used 0.4, 0.6, and 0.8. From 1980s to 2018, the net national healthcare spending per capita in the United States increased to 50%. Also, the median income of the overall population from 1980s to 2020 increased an estimate 40%. Therefore, predicted the change of the quality component of the healthcare expenditures would be approximately minus 30%, with the per capita healthcare expenditures of 220%. In this example, the observed deviation from the increase in healthcare expenditures based on the income elasticity of 0.2 would indicate that the RAND HIE is outdated. However, the changing in the income elasticity would subsequently result in the different percentage deviations. Here we have to end this video, and the next paragraph or the next information we will discuss in our next video. So till that, goodbye, tata.